Good afternoon, or good morning, or good evening, wherever you are in one of the 39 countries which I'm told are joining us for this webinar held by the International Alliance of Mental Health Research Funders in collaboration with the Lancet Psychiatry and Wellcome. My name's Niall Boyce. I am the head of field building in mental health here at Wellcome. And this symposium is really part of the follow-on from a commission which was published in the Lancet Psychiatry last year on transforming mental health implementation research. Now, if we're going to implement the evidence to provide people with better treatments and better care, the next question is, what do we mean by evidence? And that's the title of the symposium. We know that mental health is a very complex area of research. It can be a very challenging area in which to actually gather evidence in the first place. So what do we consider evidence that we can implement? What do we consider a good standard of evidence that we feel confident in putting out there into the real world to have real impact? Well, it's a big question, and so we've got a big panel and we've got plenty of time to discuss it. I'm going to take you through the panel one by one in a moment, but for now what I'll say is that this initial panel discussion is going to run for about an hour and a half. We're then going to have a 10-minute break. Then we're going to hear from two of the commissioners who worked on the original Lancet Psychiatry paper. Now, it's likely that you will have questions, and if you have questions, please pop them in the chat, or there are just the Annas in the chat, so feel free to introduce yourself as well. Tell us a bit about yourself, where you're joining from, and what you'd like to get from this afternoon. So without any further ado, I'm going to introduce you to the commissioners who will be on your screen with their cameras on, and then we'll go straight into the talks. Each talk will last for about 10 minutes or so, followed by a question or two, 20 minutes or so. So that will consist of a brief presentation followed by a question or two from me, but the group questions we'll leave till after the break, if that's okay with everyone. So I'll introduce you to the panel now. We have Dr. Gracelyn Cruden. And Gracelyn is a research scientist at Chestnut Health System's Lighthouse Institute and the Oregon Group. Her work leverages systems, decision, and implementation sciences to increase the uptake and real-world impact of evidence-informed programs and policies. We also have Stefan Gold, who is a clinical neuroscientist and immunology expert at Charité Universitätsmedizin Berlin. He's a scientific advisor to the Good Trials Collaborative, and his research focuses on biopsychosocial mechanisms, trial innovations, and evidence-based interventions for people with psychiatric and neurological disorders. We have Dr. Jessica Schleider, who is the founding director of the Lab for Scalable Mental Health and an associate professor at Northwestern University. Jessica's mission is to build, test, and disseminate scalable, evidence-based mental health solutions that bridge previously unfillable gaps in the mental health ecosystem with a focus on single-session interventions for underserved youth. We have Senior Hale Anderson, who is a research professor and Chief of Interventions at the Rockwell Foundation Interventions Unit. Senior's work uses administrative data to explore the causes and the consequences of marginalization among vulnerable groups. And her focus is particularly on translating research insights into actionable knowledge for policymakers, for practitioners, and for the public. We have Dr. Jasper Feyerts, who is assistant professor at Ghent University. And Jasper specializes in the phenomenology of psychosis and its implications for diagnosis, for treatment, and for understanding. He organizes the Too Mad to Be True conference on philosophy and madness and is a steering member of the International Consortium on Hallucination Research. Now, besides this panel, I'll also be talking with Dr. Matthew Eisenberg. Now, Matthew is a health economist, and he's an associate professor of health policy and management at Johns Hopkins Bloomberg School of Public Health, and also with Dr. Beth McGinty, who is the Livingston Farrand Professor of Public Health and the Chief of the Division of Health Policy and Economics at Weill Cornell Medical College. Now, as I mentioned earlier, they were actually co-commissioners on the Lancet Psychiatry Commission, which really spurred this webinar, the series of webinars. and they're going to be reflecting on their role within the Commission and on transforming mental health implementation research. So we've got plenty of good speakers, plenty of interest. Please stay tuned. We're going to move now to our first presentation, and that's going to be from Dr. Gracelyn Pruden. And Gracelyn is going to talk to us about mixing methods, giving us an overview of how using experimental and non-experimental methods can improve implementation. Gracelyn.
Hi. Thank you so much. It's an honor to be here with everyone this morning. So my background is in health services and policy research, which means I'm trained kind of in econometrics, very quantitatively focused, but also quite a bit of qualitative focus, as well as decision science, which means I think about how and why people make decisions regarding the health intervention selection and implementation of those interventions. And then implementation science, which means I think about how to scale up evidence, or how to get it in more places to more people, or out, so get it into a different place than it previously has been tested. So as we alluded to earlier, then my talk is just going to be really high level, then getting us kind of hopefully then the brain juices flowing around the idea of how we think about defining evidence, and then how different types of study designs then can help us explore those types of evidence. Next, please. So I'd like you to take a moment then and pause and think about how you define evidence. What comes to mind when you think what counts as evidence? So I invite you to notice whether your definition includes the source of the evidence, such as who produces the evidence. Is it a researcher? Is it a nonprofit group, for example? Whose expertise was sought out? Did it include people with lived experience? Did it include, only kind of an expert panel? And the format, what was the study design? Do you have an idea of, qualitative or quantitative data or something else then in terms of how, what comes together? Evidence can be a lot of different things. And I hope what, starting with this talk and the talks from the other wonderful speakers are going to be today kind of helps you think very broadly about the different ways that we could define evidence. And I think this is just such a critical topic because, I can speak at least from the US perspective, is that the way that evidence is defined is different in different policies in the US. And that really defines what gets funded and thus what can reach people. So we've done a really great job in science of getting, different policymakers to realize that thinking about the strength of the evidence base, or what counts as evidence, is really important so that we can hopefully get what works to people. But because we don't have consistent definitions of evidence, and because this is such a complicated and important topic, it means then that there's a lot of work to be done. Next, please. And I've actually been really interested in this idea of defining evidence since my dissertation, actually, when I was interviewing local policymakers and providers related to child maltreatment intervention selection. And I'll give you just a moment to read this quote. And I think this quote illustrates it the best, but there are quite a lot of people then. One of the resounding themes was this tension between something is evidence-based or it's innovative. And that to me feels very unsatisfactory with this idea of that, we're going to just develop this evidence base and it's going to be this perfect thing that is done and we've achieved having a strong evidence base, and then we're going to implement something. But then that's obviously going to take quite a long time. We know that on average, it takes about 17 years from the time something begins being tested as an intervention to when it reaches people in practice, if it ever does at all. And then on the ground, people are like, but we need to change things now. We need innovation. And so hopefully, as we go through this talk today, I can give you some examples then of how study designs have been evolving then to help address this problem then and that tension. Next, please. One of the other things that comes out then when I talk to local policymakers and decision makers is this idea of when do we have enough evidence? When have we, done enough studies then that I can feel good about giving this to my population then? And the thing is, coming from my decision science perspective, uncertainty is inherent to everything that we do, every decision. Even if we have an excellent evidence base, we know then as researchers, we're always saying that there's certain assumptions, there's certain limitations to the research. So how comfortable are we with the evidence base before we can scale it up? And the idea here then is that on the left, you can have an evidence-driven decision, this idea that something is truly evidence-based, we are solid and we know what's going on, and that is what counts as a good decision. But evidence-based medicine and the decision science literature says a good decision actually rests on this three-legged stool. So you have your evidence, but you certainly always have your values and preferences, the values and preferences of those of whom you're making decisions on behalf of then. So for example, if you're a policymaker thinking about your constituency, and then your own expertise and judgment. You can use that to fill in the gaps and say, well, this is what the evidence looked like maybe in the literature, but here's what I think it's going to look like in my setting. So that's where you have this mixture then of research-based, practice-based, and then data-based evidence then. And so I hope what this encourages you to think about this then is that there's a lot of different things that come in, and that's actually normal, and it's good to think about that we not only have the scientific evidence, but it comes in with this idea of our values and preferences, as well as the expertise of those in the room. Next, please. And so similarly, then we think about this idea that if we just have, the best available data, then we can infer the best thing to do and we can take action. But similarly to the last slide, then we see here on the left that, context matters. It depends on if the interventions and the data came from a setting that looks similar to ours before, our own value system, and all of that matters in taking action. But what I think is exciting is that as researchers, we get to kind of help decide then what are the available data that we want to, what do we want data we want to make available? What do we want to create? What do we want to think about? And there's a lot of different decision points we can think about in terms of deciding, what methods are we going to use, or who are going to be our sources of data, and what are our study designs. So let's go ahead and transition to thinking about study designs with next, please. So first, I'm going to discuss experimental methods. And one of the kind of big picture way that I think about that is that experimental methods are what we get to do when we have the benefit of having, the sufficient sample size that we need. And we have, to do the power analyses and say, based on the expected effect size, we need this many people to be able to feel good about drawing some conclusions about causality. It means we can do some planning. So we're able to say then I am going to decide when this intervention is delivered, to whom, when, how. We have the resources to do all that. And random assignment feels ethical. So we wouldn't feel good about randomly assigning individuals to something that we think could be harmful to them, of course. And so, experiment methods require us to balance all of those factors. Next. So what are some experiment methods? Today, we're going to focus on this idea, the idea of the gold, typically called the gold standard of randomized controlled trials. We have really strong, internal validity, thinking that we can say that we feel confident that, we've randomized units, so an individual, schools, states, very rarely, some of my work, into an intervention then, and say then that there are, and I know one of the next speakers is going to talk more so about randomized controlled trials in detail, but what I wanted to highlight here is that there's a bunch of different designs that we can try to understand that okay, well, we don't have to necessarily assign everyone to the entire intervention at the same time. We can use rollout designs to assign them at different time points, and that can be really advantageous in terms of thinking about study resources, feasibility, and acceptability to the individuals or the units that we're assigning. And then we can also use some really cool study designs called multi-phase optimization strategy, or the MOST design then, that uses factorial design. And all that thing then is saying, well, what if we don't actually know what all needs to go into an intervention yet? What if we don't know if we should have all 4 components that we're thinking about? Maybe we need 3 of the 4. Maybe it's better to take these 2 from over here and these 2 over here. So it uses a multi-phase process then to really rigorously test then and decide what components to include. And it uses of a 3-phase process then uses the randomized controlled trials in 2 of those phases then. Next, please. So just to illustrate a little bit then, so in the rollout design, there's a bunch of different ways that you can do it in terms of how you assign the sites or the units to the intervention condition. So you can assign them to start then in a staggered way then, basically. So you can also, a type of this called stepped wedge then. But what I want you to gather from here is that you will do comparisons both within and between units over time. So this is a really nice way to look at thinking about feasibility then. So saying, okay, what if it's going to be a really resource intensive intervention on the research side? And it would be really challenging to stand that up across all sites at a given time. Or what if you think that you have enough evidence for the intervention and it would be unethical to withhold it, or the communities don't want you to withhold it completely, you don't want to have a completely no intervention control. This design allows you to give the intervention to every unit eventually. Next, please. So in non-experimental methods then, I think these don't get enough credit, and I think they are incredibly valuable and useful, especially in work then when you're thinking about high risk populations then, and again, thinking about the ethic of assigning individuals to interventions then, and when you're doing policy work like I do, where we don't necessarily get to tell policymakers what policies to pass and when to implement it. And so we have to think of other creative ways to rigorously test what we think is going on. So these are when the experimental methods and some that we just reviewed are impractical, infeasible, or unethical. And so next, please. First, I'd like to emphasize in that qualitative approaches, then there's quite a few then that include, observation, thinking about ethnography, direct inquiry. So are we doing interviews and focus groups? I think those are some of the ones that people most often think of. But I also like us to encourage us to think about things like document review, policy surveillance. There's mixed method approaches even within that, like legal policy and legal mapping approaches then, where you're identifying then, how often a policy incorporates the idea of evidence. How are you operationalizing the idea of whether policymakers are using evidence just to motivate what they want to do? Is there something in the beginning of the policy document that cites a study then that's encouraged them to pass this policy? Or are they saying we actually want this particular evidence-based intervention to be implemented? There's a lot of different ways we can think about that. And then there's system science too. That's also just one of my passion areas then, because I think it's really important to think about the idea of nonlinearity and context. And what I mean by that that we know that we can't test every intervention in a randomized controlled trial in every single setting, but we know that context matters. We know that it matters if something is implemented in a small rural school versus a larger urban school, for example. And system science gives us a really nice way to start thinking through the problems that we want to address and how we might want to address it. And system science can take us from qualitative to quantitative. So next, please. So here's where we get to start thinking then about both within site designs then that would kind of be like a pre-post example then. So we're not randomizing, but we're doing some other rigorous evaluation of how a site changes effects over time. Difference and regression discontinuity comes from the health services research then, and again, saying that like a policy was implemented over time, and do we see that there are differential trajectories in groups that were exposed or not exposed to the policy or a particular intervention than what we would have otherwise expected. Of course, this includes economic evaluations. We know that cost really matters to policymakers, unsurprisingly. And then the system science simulations that I was alluding to on the last slide, with this idea of, we can use computers to give us a little safe sandbox to play in and do what if experiments. Say, what if we implemented this intervention at a given time? What if we, scaled it up for this population? If we did more depression screening in primary care, what would that do to the flow of individuals over time who start receiving depression interventions then as they should in a timely manner? So system science gives us a really ethical, safe way to explore those questions and hopefully feel a little bit better even when there is going to be that uncertainty that I was talking about earlier. Next, please. So again, just to illustrate a little bit then is that we can use difference and then to say then what we're seeing here in the middle of the circles and the squares is this idea of what is the average and here in the change in proportion of patients receiving any opioid prescription attribute to a law, that's just percentage point change then. So we're seeing before and after these opioid prescribing cap laws were implemented in these different 4 states, and then compared to a synthetic control in this example, how is that changing over time then? So we're seeing then just a nice example of that. Next, please. Here, don't worry about all of the squiggle lines and everything, but the idea that I wanted to emphasize here then is that, again, system dynamics can be really helpful for us understanding, having those, you can move to a computer-based simulation. We often think that's numbers and values. Then we're saying we're predicting how many people are reached, things like that. But what's really important then is to start with the qualitative, in that all of those quantitative models start with some kind of qualitative model that's saying, what is the problem we're trying to model? What are we trying to understand then? Where are the high leverage points that would say where we could get the biggest bang for our buck, essentially, and saying, this is what's really driving the behaviors that we're trying to impact. And one of the favorite things that a quote that comes from John Sterman, then, who is one of the founders of the field of system dynamics, that I always try to keep in mind is that when we remove a variable because we can't measure it exactly the way that we want to, we're assigning it the only value that we know not to be true, which is 0. And I think system dynamics gives us a really nice way, and then like a mixed methods approach then, to understand then what matters. Next, please. So obviously then we can make different types of research questions and conclusions then from these two different approaches. Where at the experimental, we get to make more kind of a causality claims versus association claims than in a non-experimental design. Experimental, we get to make claims then about mediation, moderation. But in non-experimental, and again, particularly with simulations, we get to think about what are the unintended consequences. We can also look at that in the qualitative data, looking at interviews and document reviews. What did people think was going to happen? What actually happened? What questions did the researchers not think to ask? But then, in the qualitative work, we can see that it came out. And it's really important then for learning and anticipating those unintended consequences so we don't have iatrogenic effects in the future. And then, of course, then I didn't get to this as much then, but we can, with those most and designs that I was mentioning in particular, we can think about how we can optimize impact. What's the right level or dosage of an intervention to give? But in the non-experimental approaches, we can also say, what are the components or thresholds that are likely to optimize impacts? That might be a really nice thing to do first before you want to, have that really strong qualitative work or other types of non-experimental designs to feed into that experimental optimization. Next, please. So, as I was just alluding to, then thinking about how you sequence your qualitative and quantitative work can be really important. Here, what I just want you to grab from this slide then is that what we really hopefully can embrace mixed methods work more. I think that would really strengthen the field. And all that we're varying here is the idea of sequencing. So are you doing your qualitative work before your quantitative? Particularly helpful, for example, if you're doing measure development or intervention development, or you're doing your quantitative first and then just using your qualitative to try to understand what you found in your RCT, for example, or are you doing those more in parallel? Next. And here I wanted to bring up the idea then from implementation science of hybrid approaches then. So these are a really fun way then of testing both the health intervention that you are interested in understanding the effectiveness of in terms of a clinical perspective, but also implementation strategies, which are the interventions that we develop in implementation science to get those health interventions into the real world. So those can be anything from, helping with financing to training and educating the providers. And so we say then there's 3 different types then that all vary in terms of how much evidence you think you have for either the innovation or the implementation strategy. And that's how you're designing your study then to develop a stronger evidence base for either one of those. And they just vary on their emphasis across that. Next, please. So hopefully today, as I'm going to wrap up then and say, is like, I hope you consider that as you're listening to the other presenters, that when it comes to evidence, there is no single source of truth. There's quite a continuum of designs, methods, people, and outcomes that will increase whether we're producing the evidence that is timely and impactful and useful. Evidence is and always should be considered relative to context, so the people, the places where it's developed. There are complementary types of evidence that can allow us to innovate and not stagnate. I always try and think of that local provider then who says that, evidence is great, but I have things on the ground to worry about and I need to innovate. And evidence generation is a nonlinear process. We should never think that we are done and we have the perfect evidence-based intervention. So with that, then, if you want to do next and final slide, I really appreciate you all for your time and I really look forward to the discussion later on.
Thank you very much, Gracelyn. So that's given us a really good grounding in this question of what evidence is available to us in mental health. But one of the issues which I've found in mental health science is that maybe unlike other areas of health, I think everyone has an intuitive idea as to what can work and what should work. So, for instance, we see this at the moment with the idea of mobile phones and mental health, and the idea that it's quite simple. Intuitively, mobile phones must be the cause of so much mental ill health in young people. and therefore we should just go ahead with banning them in schools or whatever. But actually, we don't really need evidence for this. We can see it with our own eyes. And that's just an example of how I think, people can go with the intuitive a lot of the time in mental health. And sometimes those intuitions are correct, sometimes they're not. But I wonder how you can then make the case for the kind of evidence collection and analysis which you're talking about in the face of that.
Yeah, I think that's a great question. And just to see if I'm saying, are you thinking to make the case to then maybe the school administrators then about the need for then, yeah, I think that's a great example then of where qualitative work comes in then and emphasize and thinking through of like who's going to be impacted by that. Why are they, and that's where my decision science hat comes in. Why are they hesitant to adopt that if it does seem so intuitive to them? Are they worried that there's going to be burden on the teachers for doing some kind of new intervention? Are they worried that there's going to be parental, resistance, student resistance? Qualitative work can really help you understand that. And also back to the system science, understanding what is the actual problem we're trying to achieve and what are the unintended consequences. What if having the phone then is something then that it really provides some important support then for some students given their learning capacity or their social anxieties and things like by taking something away, what else might happen? So if we can help use qualitative work to help them understand the whole context then of both the problem and what might happen, we can also think about how then to remove the barriers to do that then. So maybe it isn't the intervention that we're worried about, it's everything else. And so we can think about the different strategies and implement. That's where the implementation strategies come in to think through, okay, well, how can we think about developing a really feasible curriculum then for teachers to do this, or a way to communicate to parents how we think this is the best for their kids and they should also feel confident, for example. So that whole wraparound of the intervention, it's not the intervention, but the wraparound of everything about how it's communicated.
Thank you very much, Gracelyn. Now we'll hear more from Gracelyn later during the panel discussion. Just before I introduce our next speaker, I'll say that I have paid insufficient attention to the evidence of the schedule, and while Gracelyn spoke for 20 minutes, our remaining speakers in the panel have 10 minutes each, and the first of those is Stefan Gold. Now, Stefan is going to talk to us about clinical trials in mental health towards implementable innovation.
All right, thank you very much. Great to be here. Thanks for organizing this. And also thanks to Gracelyn for setting the stage a little bit. So what I'm going to try to do in the next few minutes is zoom in this evidence landscape a little bit on the area of clinical trials or randomized control trials in particular, and talk a little bit about that and how that could play a role in our overall evidence landscape for different things in mental health. And next slide, please. So I often start a talk with this slide and point out that research on the development and evaluation for treatments typically receives a lot less funding than research into the underpinnings or etiology of mental illness. And I think that is a valid observation, obviously. But today I want to talk less about whether we should play these different areas of research against each other and more about how we could use the resources that are available, possibly in a more efficient way, to improve the evidence base for mental health research with clinical trials. But before I do that, I would like to make 2 points that I think are crucial when we're looking at clinical trials specifically in mental health. And for that, please, next slide. The first point I want to make is this one. So what you see here is an analysis of thousands of randomized controlled trials in the mental health space. And what's plotted on the y-axis is the power, the statistical power that those trials achieved to detect a moderate effect size of 0.40. So, and I think without going into detail here, you can see that the vast majority of these trials were not powered to detect such an effect. And that, to me, either means they were all extremely optimistic as to how effective their intervention would be that they were studying in this particular trial, or they were underpowered. Probably both. And I think the thing I want to point out here that's important, this is true for all different areas of research. You can see anxiety, you can see mood disorders, you can see psychosis. And it's also true for all types of different interventions. So the blue, for example, is pharmacotherapy, the pink is psychotherapy. So there's no discernible difference. And I think that's a persuasive problem in a lot of clinical trials. So by design, many of the trials that we're conducting never really have the chance to provide a robust answer, even if they ask a relevant question. And there are ways of salvaging this, and you can do individual patient meta-analysis and all that, but I think it would still be better if they were all designed to provide a robust answer about the intervention that they're asking. And I think the point that they're possibly never have a chance to provide this reliable answer is reflected on the next slide, which is the second point I want to make. What this slide illustrates is the fate of large multi-center trials in different areas of medicine. To the left, you see S, that's surgery, P and P is psychiatry and psychotherapy. So let's focus on that a little bit. And what you see here is in gray is the number of, and these are already multi-center trials. So it's trials that by definition are fairly large and should be informative. So these are the number of trials that have been conducted over a certain period of time. The red ones are the ones that end up being published. So we do have a little problem already with publication bias. Okay, we know that. Then the blue bar is the number of trials that are being picked up in systematic reviews, so that are sort of have impact on the scientific side of things. And then the yellow part is those trials that end up in clinical guidelines. And I think the obvious problem is that even the larger trials that are being conducted, only a small proportion of those are being perceived as being informative so that they will be included in clinical practice guidelines. So I think the question would be, how do we do this better? How can we make sure that the trials that we do run ask the right questions, include the right people, and provide a meaningful answer so that they actually do what they're supposed to do, inform clinical practice. Next slide, please. So because trials, as I pointed out, at the right size, asking the right question with the right design are hard to do and very expensive, sometimes it has been suggested that we should replace them by using cheaper ways of generating evidence, observational or so-called real-world evidence. And I think that's a valid discussion to have. But we should also look at how other fields of medicine or healthcare have dealt with it. And I just want to illustrate a few examples here. If you remember, during the COVID pandemic, lots of the interventions were deployed in non-randomized fashion, for example, hydroxychloroquine, convalescent plasma, to name just a few. And sometimes they were deployed and not studied at all. So that means you're for sure not going to learn anything, right? If you're just deploying and you're not even studying, that means you don't learn anything. Sometimes they were deployed and studied in an observational fashion. That means that at least sometimes you may learn the wrong thing because you think something is effective or not effective when in fact it is not. And there's some very prominent examples from the pandemic as well. And it took some really good RCTs to actually find the real answer, like the recovery trial on COVID treatments. And so in a way, the problem there was that doing these or replacing or first relying on the observational data gave us wrong answers. And that means we lost time. We probably lost money by using ineffective therapies at large scale, and we might even have lost lives because of that. And a key lesson to me is not to replace RCTs, but to integrate them, first of all, in an overall landscape. So they need to be complemented by other sources of evidence. And there's certain things, as our previous speaker pointed out, where RCTs might not be the answer at all. But RCTs, at least when it comes to the effectiveness of treatments, play a crucial role in that evidence landscape. And so I think one way of dealing with that is to enable RCTs to be integrated into clinical care. So we can move to a setting where new treatments are used and studied in a way that enables learning and comparison between the groups. So that means something like a learning healthcare system or living evidence-based medicine, as this has sometimes been called. And I think personally that is not only something that we need under pandemic settings and for infectious diseases or cancer, but it's also something that we could employ for non-communicable health conditions, including mental health. And if we want randomized controlled trials to be part of clinical care, we have to make it easier to do them, and we also have to make them cheaper without compromising their quality. Next slide, please. One way of doing that is running RCTs in a reusable infrastructure. So usually you can see that here on the left side, usually for every intervention test, you have to set up an infrastructure for the trial, you have to set up recruitment sites, you have to get data collection systems and so on and so forth. You have to train people to do that. And then you run your one intervention, you get an answer, you dismantle the whole thing, and you build it again somewhere else. So that is inefficient in a way that it starts building the infrastructure from scratch every time. As opposed to that is something called a platform trial, where you can test different interventions in a shared environment, shared infrastructure, which has several advantages. You get to compare these things in the same setting. You have fewer participants who are on control conditions. You have increased statistical power and more flexibility. And that is something that came out both of the oncology field and as well later on in the pandemic, but it has started to get some traction in the mental health field as well. If you go to the next slide, there's now several of these trials being planned or launched. There's one in the US using such a design of a platform trial in post-traumatic stress disorder. There's one that's being launched in Europe for treatment-resistant depression. Right now, they're all still focused on drug development or evaluation of pharmacological therapies, but in principle, they would be suitable for all types of interventions. And they do have some challenges, so it's a bit tricky to design them, but they are feasible and they can be implemented even in mental health. The problem is that having such a semi-permanent infrastructure, a reusable infrastructure, is something that goes beyond the typical 3 to 5 year project grant funding that we typically have for things that we want to study. So we need new ways of funding, new ways of collaborating. One way is maybe to tie these initiatives into national infrastructure investments for mental health research. There's a couple of examples. In Germany, we have the German Center for Mental Health. In the UK, there's the UK Mental Health Mission. There's been an establishment of a trial network in Australia, and there's others. So if you combine these initiatives, maybe you can overcome this barrier of sort of everything is in project size and never made to build in a more efficient, more durable way. So to summarize, last slide, please. I think implemental innovation, if it requires RCTs, and I think for some of the questions that we have, we do need RCT and we can have RCTs, but they have to be run in the right scale and in the right setting. There's a certain random magic to randomization in terms of inference of causality, as our previous speaker has pointed out, but it does require us to change the way that we do research a little bit, at least for this segment of our innovation landscape. And I think one thing that's particularly important is that if you have an evidence generation model like that, you need people who are supporting it, who are working on it. And for that, we may have to change the way that we reward scientific careers, because these things are so big that they can't be done by small groups or individuals anymore. And we need to divorce that from the fate of the careers, and we need to create incentives and reward systems for people to actually engage in this type of evidence generation. And with that, I'm at the end of my talk. I hope that gave a few pointers towards how we can think about this part of our evidence landscape. And now back to you.
Thanks, Stefan. So there's one question I have, if I might press you a bit on this, which is that while clearly we do need to do trials at scale, and that scale brings efficiency, one of the concerns I've heard is that when you get trials which are running over multiple sites, maybe the quality of individual assessment of participants goes down, and this might be one of the contributors to one of the big problems in trials, which is the rather high, and some say increasing, placebo effect, which we're observing, which means that the trials essentially fail. Is it possible to do trials at scale with quality assurance, or will there always be a trade-off between those two in terms of generating the evidence that we need?
Well, in a way, it is a problem if you go to multiple sites and you have different people involved. I think there's several things that you have to consider. The first thing is that it also increases generalizability, because the actual world is also full of noise. So if you want to go across different settings, maybe that gives you a more realistic picture of how these interventions would later on fare if you actually deploy them outside of clinical trials. So a failed trial to me is not necessarily bad sometimes. I think a good trial will always provide a robust answer, and the goal is not to find a positive finding. The goal is always to find a robust answer. And the second part I want to emphasize is that one advantage of these infrastructures where you can run several trials and you don't start everything from scratch from a new trial, that also means it's the same people, and people get used to running these trials, and people get routine in assessing things in a clinical trial and documenting them the way that we need this data to be. So in a way, not having to tear down everything, set it up from scratch will increase data quality and reduce variability across sites, because people are used to doing this type of work, and that will actually increase the data quality and therefore give you more signal over noise.
So it sounds as if part of it is that we need to get into the habit of running these trials, that we need to get used to.
It's what in other fields they call it a warm base research, that so that you have you keep the motor running and you test one intervention after another rather than cold start every time you have a new question.
Thank you very much, Stefan. So as with Gracelyn, we will hear more from Stefan later in the panel discussion, but for now we're going to move on to our third speaker. And this is Dr. Jessica Schneider, who is going to talk about Uplift the Web, a mega study to surface what works in mental health innovation and intervention. Sorry, Jessica.
Thanks so much. I'm just going to share my screen and we'll get started hopefully within a minute. Great. Thanks so much for the opportunity to share about our work and project today. I'm going to dive right in because we have a lot to get through in 10 minutes. So we're all on the same page, I think, that meaningful transformation of the mental health care system is going to require us to reckon with three really difficult realities. The first is that the vast majority of people who need mental health support do not access any. The second is that the supports that do exist are often structurally incompatible with how many want to engage with support, particularly young people and young adults who say that they want support online when and where needs arise right away, rather than waiting sometimes months for a therapist, and using self-help tools, not just professional providers, due to stigma, cost of traditional treatment, or preferences just for self-management. Reality three is that despite our development of interventions for the past 5 or 6 decades that last weeks to months long, the most common number of mental health support sessions that people actually access, if they get in the door at all, happens to be one. And that is true for both online and offline interventions, suggesting that we may need to rethink how we design interventions to better match naturalistic engagement patterns. And those are some of the reasons that our lab, the Lab for Scalable Mental Health at Northwestern, has focused so much attention and work on digital single session interventions. I want to quickly define this because this will be important for the rest of the talk. SSIs are specific structured programs that intentionally involve just one visitor encounter with a clinic provider or self-guided program. Intentionality here is key because if you just show up for what should be an assessment at the beginning of a longer course of therapy but don't return, that would not be an SSI, that would be early dropout. SSIs can be accessed once or on many occasions, as and when they're needed. This is a one-at-a-time approach to supporting people, not a one-and-done approach. And they can be digital and self-guided, which is what I'll be talking about today, or human-facilitated, either by lay providers or professionals, and accessed within or outside formal healthcare settings, which really enhances their scalability. In all cases, SSIs drop the often false assumption that people are going to return for another session, while instilling the actually true belief that meaningful change is in fact possible at any moment and for any person. They're designed to instill this context of competence in the user. This isn't just a good idea. Decades of research suggest that single session interventions can actually affect meaningful clinical change and enhance uptake of other services. If you're interested, we just published an umbrella review of systematic reviews and meta-analyses of SSIs, including 24 systematic reviews in 415 SSI clinical trials, including over 50,000 participants. really strongly supporting the possible benefits of SSIs for youth and adults across a wide range of problems. I'm not going to go into this in too much detail, but if you're interested, this was just published in Annual Review of Clinical Psych. Evidence-based digital self-guided SSIs, as in those that don't involve a provider and that are accessible anywhere by anybody at any time, are designed with a variety of core components traditionally. They include things like psychoeducation, teaching about brain science, some peer narratives to enhance a sense of relatedness, an action plan to help implementation of a specific skill, usually a skill from an evidence-based treatment protocol that's longer term, and opportunities to share advice to solidify learning. And existing evidence-based SSIs are already widely scaled. Our lab's SSIs, through partnerships with multi-sector organizations, have reached more than 70,000 people to date. However, although existing SSIs, quote, work per clinical trials and standard evidence in the field, I think they could be better. The overall effect size of single session interventions is small, particularly when scaled to large populations. And the work on single session interventions, as is the case with work with all psychotherapies, has relied on a very top-down structure of design and evaluation. As in, we've systematically excluded folks with lived experience perspectives from any part of the intervention idea generation, development, pipeline, or evaluation or selection process, which I've written about before, is a very big problem in our field, and I think constrains the scope of evidence we have to draw from. So our lab decided to embark on a project that we thought would be really exciting to identify more effective SSIs for depression specifically, which is a major public health problem internationally, through a crowdsourced mega study. This is called the Uplift the Web Challenge. I want to say that I'm presenting this today, but this effort has been spearheaded in a major way by my postdoc, Benji Cavaladze, who's on the job market right now. So I want to give him a shout out for this wonderful project. So for this study, we sought out to crowdsource a diverse set of promising SSIs for depression, drawing ideas from anybody who wanted to submit them, not just professionals, but folks with lived experience, lay, non-professional folks, kids and youth who had ideas for how to better address things through digital online content. And then we're about to start conducting a giant mega study of which one works best. And our plan is to disseminate the winners of that mega study online for free through our existing nonprofit partners. Now, what do I mean by a crowdsourced mega study? By crowdsourced, I mean we invited SSI submissions from many teams anywhere in the world at any age group with no restrictions on training or background. Anybody could submit an SSI or just a rough outline of one, and our team would help them refine that into a submission that met eligibility criteria. And a mega study is an experiment that compares many interventions at once, which is in stark contrast to the traditional field experiment, or RCT, which is conducted by maybe one team and compares two possible conditions. A mega study takes ideas and resources from multiple teams, combines all of those ideas, and compares all of them at once to enhance efficiency and increase the likelihood of finding new innovative ideas that actually work. This isn't the first mega study that's been conducted, but none have been conducted in the field of mental health research before. As an example of one really well-conducted recent mega study, a team at Stanford led the Strengthening Democracy Challenge to test what brief online activity could best reduce partisan animosity. And despite all these evidence-based social psychological strategies that were tested in this mega study, the thing that they found best addressed partisan animosity was actually a 5-minute beer commercial. So that what they labeled a positive contact video of two people who disagreed politically sharing a beer was by far the most effective intervention. Not created by a scientific team, not created by researchers, but that just goes to show we don't know, just if we rely on our own knowledge alone, what is going to work best and resonate with people. We created a public website and invited anybody to submit. We advertised all over the place, social media, college campuses. We reached out to international partners and agencies that were not research focused. This is the core research team. And we had a team of principal investigators all across the US who are expert in digital mental health broadly. We created a handbook and video guides for people to prepare their submissions, because we knew that we wanted to give everybody a fair shot at knowing how to even put something like this together, a proposal for a digital single session intervention. So we had very explicit criteria and instructions. The goal was for even a motivated senior in high school to be able to understand. These were just the eligibility criteria. Anything ethical and online that could reach 500 plus people in a day, as long as it might reduce depression in a self-guided format of under 10 minutes. It could include video, text, audio, or free response. And we wanted to compare established SSI designs to totally new ideas. We had a multi-stage project for selecting which SSIs were chosen for inclusion in the mega study. We actually got more than 80 submissions. So that was wonderful from all over the world. But first we did an eligibility review and then sort of culled the list down to 20 that best fit eligibility criteria and that were sufficiently clear to be testable in a mega study like this. We then had an advisory board review, which consisted of scientists to review and rate systematically each SSI on a predetermined Likert scale. You can see the rating form there. And after that, the research team shared the reviewers' feedback with the top 20 submitters and worked with them to implement the suggested changes. And by the way, the 20 that we ended up with represented a cross-section of submissions from research teams, young people, and folks who were popular online influencers who wanted to try to submit, and various other teams from all over the world. We then did usability testing and input from experts by experience. So this involved using the platform B-sample to ask 15 folks with lived experience of depression from all over the world to evaluate each SSI, again, providing a rubric for them to do so. And lastly, the PI team, which I was presented before, triangulated the evidence from both the experts by experience and the investigator team to equally weight both of their ratings and feedback, both qualitative and quantitative, to select the final 10 for inclusion in the experiment. We ended up with a really wide cross-section of SSIs, from AI generation, AI-generated response and feedback, to commercials, to YouTube videos that folks had posted from folks with lived experience and from professional psychologists, to a few that follow more like traditional psychoeducational activities. This is going to be a really large trial where we compare all 10 SSIs to an active comparison condition, the ABC project, which is an evidence-based behavioral activation focused SSI. And we're also concluding a passive control, which is a 10-minute video about trout. So we're using both an active and passive comparator to see really how do these fare against each other and against controls of various kinds. We don't know what we're going to find because we are just about to launch this study. One thing I will say, particularly to this audience, this was not a study that we were able to seek funding for through traditional avenues. We fundraised to do all of this from a variety of sources, and we're very grateful for our backers. But because this is such an out-of-the-box approach to evaluating psychotherapies, there was no good fit mechanism that would have allowed us to pursue funding through traditional sources. So we're really excited about what we could find, because we can examine all sorts of patterns and find all sorts of winners or lesser performing ones. We can find out if SSIs with videos are better than more effortful text-based interventions, whether SSIs that adhere to principles of CBT perform better than those that don't, whether certain groups of users tend to prefer or benefit more from SSIs. And by the way, we're recruiting our sample of 7,000 young adults with depression from Cloud Research, focusing on the US. And then we're going to select the winners, and we have established partnerships with organizations like Mental Health America, the largest advocacy mental health group in the US, and COCO, which deploys brief interventions on social media platforms to make sure that those that work actually reach people in need. Thanks so much, and apologies for going about a minute over, but looking forward to any questions folks have, either now or in the future. Feel free to contact me.
Thank you very much, Jessica. That's a fascinating study. I just wonder if I could learn a little more about something you mentioned there in passing, which is that you had to raise the funds for this yourself. And I wonder what it was about the usual funders, which meant that you couldn't get money through that kind of route for this study? What was it? Was it something about the speed at which you're working? Was it the nature of the work? What was it that switched off those sources of money for you?
So it was a combination of factors. One was absolutely the speed. We wanted to go faster than traditional funding mechanisms would ever have allowed us to do. Although I reached out to program officers at various funding organizations in the US, and basically what they said is there were too many possible variables and outcomes to be considered, and it would be complicated to understand the results. And another program officer told me that it's not viable to include interventions that are in no way evidence-based, by which they were referring to those contributed by folks with lived experience or online influencers. They said the content would be too variable to understand the meaning of it, even though we said we would code things. And I also think that this mega study approach just isn't something that they typically see. So they weren't quite sure where to place it in the context of things they'd funded before. There's also the factor that single session interventions in general are something that often requires a lot of explanation in grant proposals. So the combination of all of those factors led me to receive the advice that maybe this isn't the best fit, but we were able to raise the funds to do the entire trial ourselves.
So this almost puts us back to a few things which I was just talking about with Stefan, which is that we have the tension between the sort of messy, complex, real world and perfect experimental conditions, and what we might consider to be an experiment where we know absolutely all of the variables involved and we can control things very carefully, versus the fact this has to be implemented in the world where things are not quite so tidy. And then there's the question, which is really overarching for this whole webinar, which is what counts as evidence? Who counts as a source of evidence? And what I think you're saying there is that one can have lived experience, but as far as some people are concerned, that's not quite evidence as we know it.
That's exactly right. The feedback was really the opinion of folks with lived experience, and the experiences that they have in benefiting from something doesn't count as much as there needed to be a randomized trial of each intervention we were testing already.
Thank you very much, Jessica. I look forward to picking up on some of these points later. For now, though, we're going to move on to our next speaker, who is Professor Sinja Helle Andersen. And Sinja is going to talk about research after a disaster, using natural experiments to guide mental health policy response. Sinja.
Yes, thank you. And thank you for inviting me to this important and really interesting symposium. Thank you so much. I have to say I'm a sociologist by training, so it means that I do not come from a mental health area, but I've studied, as you also said initially, marginalized groups, among which I guess also people who struggle with mental health problems count. Next slide, please. So my talk will draw a lot on this study that I published together with co-authors Leah Richmond-Reckert, Terry Moffitt, and Avshalom Caspi in PNAS in 24, which is a study where we leverage a natural experiment, which is a fireworks factory disaster, to identify a causal effect of developing a stress-related mental disorder on labor market outcomes. In the study, we use administrative data from Denmark. So we have this data in Denmark that covers every Dane in a range of domains where the Dane interact with a public or private institution. So it's essentially a panel that covers the period from 1980 till present day. In the study, we find that stress-related mental disorders increase the risk of going on sickness benefits in the short and long run. We also show that developing these types of mental disorders increase the risk of using unemployment benefits in the long run. And then finally, we show that stress-related mental disorders increase the risk of losing wage income in the long run. Next slide, please. So I think we've all made the observation that working adults who experience mental disorders also tend to have more difficulties in the workplace and in the labor market. This could be due to low motivation, fatigue caused by the mental health problems, issues related to social withdrawal, etc. So we know this from observations, and we also know it from correlation studies. And we have this intuition that it's the mental health disorder that caused these difficulties. However, it could also be vice versa, a case of reverse causality, where struggling at the labor market causes stress and other types of mental disorders, so that the arrow goes in the other direction, that the labor market difficulties are essentially the originating cause. But it could also be that there's a common third factor, like a spurious correlation that determines both the risk of developing mental health problems and labor market difficulties. So essentially, when we observe this correlation in real life, in our work, it's not necessarily an indication or evidence that it's the mental health problem that causes the labor market difficulty. However, when we look at research, the current state of the research base, we have relatively limited evidence of this causal effect that mental health is causing labor market difficulties. Next slide, please. So in my research and the study that I'm drawing upon here, we use econometric models to provide causal evidence on the link between mental health problems, which we now term a treatment. I know this is not the case looking from a medical perspective, but we term the mental health problem here the treatment. That has an effect on a specific outcome, in our case, the labor market outcome. And we can make causal inference or claim causal inference if we're able to deal with first the reverse causality that labor market difficulties could cause a mental health problem. And also if we're able to remove the spurious correlation element from the equation. And the key in this approach is to isolate and use exogenous variation in the treatment. That happens when the individual receives the treatment for reasons that are unrelated to the individual him or herself. It reflects the randomized control trial that Stefan was talking about earlier. So in our case, it's when an individual develops a mental health problem, it receives the treatment in our language for reasons that are unrelated to his or her own characteristics. Next slide, please. And I was just thinking about how to describe what a natural experiment is, and we could all look it up online, and I did that and found Britannica, the online lexicon, that describes the natural experiment in a way like this. It's an observational study in which an event or situation that allows for the random or seemingly random assignment of study subject to different groups that is exploited to answer a particular question. And a natural experiment is often used to study situations when the control experiment is not possible, either because of practical or ethical reasons. So in this particular setup, it's difficult to imagine a situation where we can randomly allocate a mental health problems. And even if that was possible, it wouldn't be ethically defendable. So with the natural experiments, we overcome some of these obstacles in situations where we want to look at treatments that cannot be randomly assigned. Next slide, please. Yes. So I'm just trying to explain what happens when we use a natural experiment. So imagine that we have a group of people who have different latent probabilities of developing mental health problems. So to your left, you have a guy that's very close to the 0% risk. To your very right, you have someone who's very close to the 100% risk. And then at the middle, there's someone who's sort of, at a 50%, maybe a 50% or 40% risk of developing mental health problems, and close to the threshold where he or she meets a sufficient number of diagnostic criteria to receive a diagnosis. Next slide, please. So with the natural experiment setup, we have a situation where there's an external shock that moves these people on this sort of underlying latent continuum of risk of developing mental health problems. An external shock that's unrelated, where the exposure of the risk of being exposed to this external shock is unrelated to underlying individual characteristics. Next slide, please. So what happens is then that the external shock push the individual along this line. For the guy that was closest to the 0% risk of developing mental health problem, he or she is still below the threshold of meeting a sufficient number of diagnostic criteria to receive the diagnosis. The guy that was close to the 100% underlying risk is now even closer to the 100% risk, but doesn't cross the threshold of receiving this diagnosis. But the guy in the middle moves from the one to the other side of this threshold. And now, because of the external shock that doesn't have anything to do with his or her own characteristics, he or she now meets the sufficient number of diagnostic criteria to receive a diagnosis. Next slide, please. Yeah. Oh, sorry. Next slide, please. So see, there's no relevant change to the people at the very right and the very left, but the guy in the middle now has developed a mental health issue due to the external shock. Next slide, please. Next slide, please. Just someone. Yeah. So what we do in this setup is that we compare the people in the group who are exposed to the external shock, of which some develop a mental health issue due to the shock, with a comparable group of people who are not exposed to a shock. Next slide, please. And what we do in the model is that we compare these two guys, the two guys in the middle, where the guy on the top developed a mental health issue due to the external shock, and the guy below did not, because he or she was not exposed to the shock. But they are essentially similar and had the same initial risk of developing a mental health problem to begin with. In our particular setup, the paper that I am drawing on here, we use this exploding fireworks factory. Next slide, please. And the explosion happened in this small suburb to a larger city called Kolding in Denmark, where on November the 3rd, 2004, a fireworks factory exploded. So 2 workers at the fireworks factory dropped a box of fireworks, and it set off a massive explosion. At this point, it was illegal to have fireworks factories in residential areas. So around this factory, there was a lot of family homes that were devastated as a result of this explosion. It's considered the worst disaster in the Danish context since World War II. So it was a massive thing. We know from other studies that there was significant both short and long-term mental health consequences among individuals who lived close to the factory, and more particularly, a lot of people developed post-traumatic stress disorder as a result of this explosion. In the study, we compare the labor market outcomes of individuals who developed a stress-related disorder, got the diagnosis as a result of the explosion, and their labor market outcomes to labor market outcomes among similar Danes who did not live close enough to the explosion to be affected by the disaster. Next slide, please. And it's in this setup that we now see that those who developed a stress-related disorder as a result of the explosion experienced increased level of sick leave. So within a year, they now had the sick leave take-up increased by 20 to 30 weeks. So out of the 52 weeks of a year, so more than half. Their unemployment rates went up in the long run after 5 to 6 years, and they experienced substantial wage drops in their wage income also in the long run. So what we studied here is a case where we were not only interested in mental health or mental health problems from a health angle, we were interested in also widening the perspective and saying that when we look at this type of problem, it affects multiple domains. So in particular, the workplace, but it could have been expanded to also see how does it affect the children of family who grow up in these communities? How does it affect collaboration, democratic participation, you name it, solidarity in local communities? How does it affect the political processes, etc.? So we want to emphasize that, or highlight that with this study, we emphasize how mental health problems is not just about health. Next slide, please. Yes, and so now I'm representing one methodological perspective, sort of the hardcore econometric way of looking at stuff. And that's what I've been doing throughout my career, looking at using these setups for causal inference. But I think it's becoming increasingly clear to me, but hopefully the research community as well, that with the causal estimate, we have just one building block. And obviously we need multiple causal building blocks to understand what's going on. But I guess an important next step would be to make further explorations of what it is that explains these effects. And that's where the causal effect setup that I'm representing here faces limitations. So we cannot, with the stuff that I'm working on here and presented, get a clear sense of what are the underlying mechanisms that's leading to this. Furthermore, when we look at these consequences, the causal effect of mental health issues, it's not just about what goes on in the individual, it's also how our community responds to people with mental health problems. And I think my message here today would be to acknowledge, obviously, the perspective that I'm representing with the causal stuff, but that we have to triangulate data sources, which I think is also what many of the previous speakers have been pointing to, that we cannot understand this phenomenon with only looking at one type of evidence. And I think that requires mutual respect across disciplines. I think we often face prejudice from different types of disciplines and methodological stands against other types of producing evidence. And I think we need to overcome that problem to really understand the social phenomena and the mental health phenomena that we're looking at. And then last slide, please. Yes. And so going back to the question that was raised here is what policy responses can the natural experiments inform? And I think obviously by looking at and identifying a causal effect of this issue, we can help point politicians and policymakers in a direction where it would be a good place to make interventions. But I think also it's important at the overall scope is to have the causal studies point to areas where we need more knowledge that cannot be produced with the causal effect studies. Thank you so much.
Thank you very much, Sinja. So one thing which I'm interested in here is that you're talking really about planning for the future in this kind of research, but natural disasters, industrial accidents, these things are by their nature unpredictable. So how is it that we can actually have research agendas which are ready and good to go? Because when these things happen, the data which it can be very important to collect to inform the response now and the response to future similar events, that data is only going to be around for so long to collect. So how is it that we can actually really forward plan to gain the kind of evidence that we need when these events happen?
I think that's a tricky question. From a Danish perspective, so we have the sort of the benefit of this register data, which is continuously collected, not for research purposes, but due to all the interactions that we have between citizens and the welfare state. So every time you go to the doctor, it's recorded. Every time you receive unemployment benefits, etc. And this is something that we have in Denmark, but it's actually also something that's available from a range of other countries, the Scandinavian countries, the Netherlands, New Zealand. I know there's also huge efforts to collect the admin data that's also available in a US context, for instance. So I think it's also being aware of these data sources that are actually collected, not for research purposes, but for other reasons. So there's some stuff going on. And then I think, for instance, the evidence that demonstrated these mental health responses to the fireworks disaster that we focused on in our study is actually based on psychologists collecting data in the aftermath of the disaster. So I think it's also being ready to move out there and collect data when these things happen.
Yeah, so we need the structures in the first place, so that long-term structure of granular data collection, but then also that expertise and readiness to actually collect the data and to ask the right research questions as and when it's needed.
Yes, I agree.
Thank you very much. We're now going to move to our final speaker, who is Dr. Jasper Faerts, who is going to talk about the phenomenology of psychosis and how qualitative research methods can improve understanding of mental health conditions and inform development of innovations that matter to people. Jasper.
Yes, thank you, Niall. I hope that everyone can see my slides. I suppose so. Okay. So I would like to begin my talk on the role of phenomenology in mental health research with the following quote by Oscar Wilde, which helps to highlight what I consider to be a crucial type of evidence in mental health research, one that is often risks to be overlooked and neglected. I quote, "It is only shallow people who do not judge by appearances. The true mystery of the world is in the visible, not the invisible." And I believe that Wilde was emphasizing the importance of attending to what is, in a sense, always right before our eyes. So the immediate dimension of human experience in our attempts to understand others. And so there's an unsuspected richness and complexity to this field of appearances. So a sense of mystery in Wilde's formulation, which will be missed if we concentrate too quickly on what lies beyond or beneath, say, on the underlying causes of experience. And I think that Wilde's call to save the appearances, to save the phenomena, remains highly relevant in today's research context, which is dominated by brief, structured, quantitative measurement approaches and a continuous search for ever more efficient forms of data collection, as can be seen, for example, in digital phenotyping. Now, such approaches have, of course, obvious clear advantages as they allow for swift and for large-scale data capture, but they do have the inevitable effect of simplifying the phenomena that we are interested in mental health research, and thus to miss out on Wilde's sense of mystery. Now, I want to argue that attending to the depth and complexities of subjective experience, which is the main aim of phenomenology and phenomenological research, which is the discipline I'm working in, that this should not be seen as a kind of aesthetic side quest for researchers, romantic researchers with too much time on their hands, but rather as a crucial part of scientific inquiry if we want to generate evidence, high quality evidence with real world validity and impact. And I will illustrate this through the example of psychosis research and research on delusions specifically, which are one of the core symptoms of this condition. And on the face of it, delusions have considerable potential to evoke a Wildean attitude of mystery and of wonder, as they can involve claims which seem to defy some of our most basic intuitions about ourselves and reality. So, for example, the belief that others can control or can access one's own mind, or that one's own mind can influence events in distant corners of the universe. So such beliefs stretch our empathic imagination, which is the reason why phenomenologists have devoted great efforts to make such delusions more intelligible by describing in detail the experiences that accompany them, which involve wide-ranging alterations in the experience of self, of space, time, and reality. Yet for a number of reasons, phenomenology remains at present a rather marginal approach in mainstream mental health research, which is often less enamored by the finer specifics of subjective experience. And of course, there's an obvious reason for this. So we all know that conducting good scientific research is demanding, is time-consuming, is expensive. So why wallow in Wildean Mysterianism if we can achieve our aims by settling for less? And in the case of delusion research, this pragmatic attitude has led to the adoption of the simplified definition of delusion as a mere false belief, which has then subsequently guided various areas of psychosis research. So for example, in explanatory research, that simplified false belief conception has spurred research into the supposed reasoning errors that would underlie delusions. And in clinical treatment, the same conception has motivated therapeutic strategies that are aimed at correcting these presumed reasoning errors. Yet, despite decades of research and numerous clinical trials, both these fields have suffered from a lack of convincing empirical support. So no study to date has been able to demonstrate a specific convincing link between reasoning errors and delusions, and also the efficacy of our psychotherapeutic interventions for delusions is consistently within the low range. So then, to return to Oscar Wilde again and his dreamy attitude of wonder, how would a phenomenological focus on subjective experience be of relevance here, and I'll consider this relevance for mental health research in general, and again illustrated through the example of delusions. So first of all, phenomenology can ensure that explanatory models in mental health science, whether they are psychological, neuroscientific, or social, that these remain grounded in the actual phenomena they aim to explain. And this seems to be an obvious point in the sense that any theory of X should at least reflect the phenomenology of X. But the example of delusions illustrates how there can often be a tendency for theories to drift apart from the actual phenomenology, or in Wildian terms, to overlook the mystery of the visible by concentrating on the invisible. And in the case of delusions, for instance, phenomenological research shows that they are typically not experienced by patients as reasoned conclusions, but rather as immediate revelations which bypass rational and irrational inference. And so acknowledgement of this phenomenological fact would have made poor reasoning explanations seem unappealing from the very start. On the other hand, phenomenology also shows that such delusional insights, revelations, take place within a different kind of reality experience. And this has helped explanatory theories to refocus their efforts on identifying the mechanisms that generate this kind of reality experience, as we can find, for example, in work on the predictive coding approach of psychosis by Corlett and colleagues. So we can see that phenomenology can both restrain and can guide development of theories in explanatory research. In a similar way, phenomenology can also ensure that treatments are attuned to how mental health problems are actually experienced by patients. And this would seem even more important than the fit between phenomena and explanations that I just mentioned. So we can expect that treatments that fail to match the subjective experience of patients are unlikely to instill a sense of being understood, which we of course know is crucial for a good therapeutic relationship and thus for the efficacy of interventions. Yet here again, the example of delusions illustrates how alongside the theory phenomenology drifts that I just mentioned, there can also be a therapy phenomenology drift. So CBT interventions have emphasized the rational evaluation of delusions, pitting these irrational and false beliefs against the standard of everyday reality. However, this approach has overlooked the fact that reality itself is no longer experienced in the same way by patients, a fact that is illustrated by the following quote of a patient with delusions who received CBT, and which I mention here to illustrate the impact the mismatch between experience and interventions can have on the quality of therapeutic relationships. I quote, "This is such a struggle in therapy. It will always be so much easier to simply capitulate that such and such is not reasonable, even though one continues to experience it. I often feel like the stereotypical political prisoner in the gulag who is told again and again to repeat and to evince true belief that the sky is pink or that 2 + 2 = 5. So a greater respect for the phenomena allows one to avoid this type of a mismatch and also to guide the selection and the development of clinical treatments that are in sync with patients' experiences. And such interventions that stay close to the phenomenology of mental health problems may not only be more efficacious, they also allow offering patients a form of empathic understanding which perhaps can only be reached through a Wildian respect for the appearances. So to conclude, these were just two examples that illustrate the role phenomenology can, and I believe should play to generate evidence in mental health research that is effectively grounded in the subjective experience of patients. And similar illustrations can be offered for other domains of mental health research because the adequate or inadequate representation of subjective experience affects all these domains, be it diagnosis, clinical prediction, etiological research, or therapeutic research. And all these examples serve to show how a healthy dose of Wilde's Mysterianism, as practiced in phenomenology, is in fact a necessary condition for achieving the pragmatic, most down-to-earth aims of our mental health science. Thank you for your attention.
Thank you very much, Jasper. So my response to that is that while phenomenology can access the truth of an individual's experiences, it's another Oscar Wilde quote, the truth is rarely pure and never simple. And it's certainly not simple to weave it into the current extremely quantitative thinking in terms of research and publishing. So my experience, for instance, of taking qualitative material into high impact journals is that people will ask questions like, well, isn't that rather a small n you have in the study? Or how do we know that the sample is representative? So it's almost as if there's a need to communicate not just the insights you can get from phenomenological research, but actually what it is that you're doing, how it works, and that it works differently to other forms of research and yet is also valid. So I wonder if that's been your experience and how you've addressed that problem.
Yeah, absolutely. There's a huge barrier that we need to cross with qualitative and phenomenological research, and we are often offered and asked questions that are rightly that are come from quantitative research approaches, and it's then often up to us to demonstrate, in fact, how our kind of research could, in fact, help these other research traditions to actually advance their own research goals. And this is at least one of the things I often try in my own phenomenological research. So not only to offer a description of the results of our research, but also really to invest time and attention to show how our insights, how the results of our research can actually inform other research approaches that are often guided by different methods and methodologies. So, yeah.
Thank you very much, Jesper. Now that is a point which I think we'll pick up on in the panel discussion, which is going to follow. But for now, many thanks to all of our panelists, and thanks to you for joining us online. We're just going to take a very short break. So what we're going to do is take a break for around 10 minutes. We're going to come back at around 10 past the hour. And when we do, we'll have the whole panel together. I'll be asking a couple of questions. If you have questions, please pop them in the chat, and we'll just get around to as many as we can in the time. So take a break, and I'll see you in 10 minutes. All of the panel could switch their cameras on. That would be fantastic. Thank you. Again, in just a minute. Brilliant. So for this panel discussion, I'd like to start off with a very broad point. And this is really dating back to when I was at medical school. And we were taught about the idea of evidence versus opinion, and what counts as evidence and what counts as the very best evidence that we would feel confident in applying in healthcare. And it looked very like an image, which I've just popped in the chat. But for those who can't see it, I'll just describe it to you. It's a pyramid. And at the top, we have the strongest evidence. And at the bottom, we have the weakest evidence. And the weakest evidence is labeled as things like case reports, opinion papers, and letters. As we go up the pyramid towards the strongest evidence, we go through animal trials, cross-sectional studies, case controls, cohorts, RCTs, and then finally, at the very top of the pyramid, we get to meta-analyses and systematic reviews. Now, the discussion which we've had so far today suggests to me that this isn't really the case at all, that there might not be a hierarchy of evidence from the best to the worst, but it might be more a matter, at least in mental health, of asking what evidence we need and for what indication, and what the limitations are and what we know, and where we have to use judgment in the face of that uncertainty. So I'd like to put that over to our panel to really ask, does it help to think about evidence in this hierarchical way from best to worst? Or is there also a more multidimensional, holistic way we should be thinking about evidence for implementation in mental health? We'll start with Jasper.
Yeah, thanks. I guess hierarchical evidence seems to imply that there is only one type of evidence that we can approach through methods, different methods that actually vary in quality, whereas in reality, there are in fact different types of evidence which also require different dedicated methods. So for example, in order to know what a hallucination is, to know what a psychosis is, I will need to consider how these phenomena are actually experienced by patients. And for this, of course, obviously, so qualitative research methods are seem more appropriate than quantitative approaches, whereas the issue would be different, of course, if I want to study the prevalence of hallucinations in epidemiological research. We need methods that are able to cover a large area, and in that sense, although one would hope that this type of research is also informed by qualitative research in the type of questionnaires it uses in its design.
So yes, and that doesn't mean that within types of study there can't be higher or lower quality of that individual study type, but it's more as if the label you give to a study, whether it's a cohort study or qualitative or whatever, doesn't actually have any bearing on its place in the hierarchy. Sinya, I wonder what your thoughts are on this.
Yes, I also think that talking about a hierarchy is not very helpful when we want to understand real social phenomena. Especially types of criteria we need to put into the knowledge that we produce. The systematic production of knowledge, that should be the criteria for whether we can use it or not. We can also talk about whether it should be possible to always replicate the knowledge that's generated. It may be something that can be challenged in specific, I guess, qualitative setups. But I do think that we need to think about the quality of knowledge based on how it's produced, or the systematic nature of how it's produced, rather than the specific type of method that's being employed.
Thank you. Jessica.
Yes, So I think I have a couple of thoughts. One relates to a question I saw in the chat about the need to change the narrative about the value of lived experience perspectives as evidence itself. I am not a fan of this hierarchical image, partially because I think of evidence generation as much more of a series of concentric circles, where there are multiple sources of possible knowledge and insight that are all critical to contributing to where all of the circles overlap, which is as close to the truth as possible. What is disappointing about this figure, which I was shown in graduate school also, is that all of the evidence is generated directly from experts. There is no source of information beyond folks with PhDs or MDs or the highest possible degree in their field. All of these things are, peer-reviewed publications that really only scientists have access to. And there's no way in for anyone else to contribute meaningfully to a hierarchy like this. And as you get higher on the hierarchy, the problems in that myopic view are just compounded because your meta-analyses are going to be systematic reviews and syntheses of all of this evidence that comes from this one perspective. So it's going to just magnify the problems over time. So what I hope to see in the future is a more holistic understanding of where evidence and information can come from that needs to contribute to understandings of what works in mental health and what is truth and what is not. That takes into account multiple perspectives and also maybe democratizes the weight of different kinds of sources.
Thank you, Stefan.
Yeah, thanks. So I think so one way that I like to think about these things is typically more, does the method used to generate a piece of evidence match the question that is being asked? And I think that's a very different, and there's totally hierarchies in that. They can be upside down or ranked a different way, but there could be a completely inappropriate method for a certain question. It's not that the RCT is always the answer to everything. There's certain questions where it's completely inappropriate to establish that evidence with an RCT. There are certain aspects where I would say it's a very narrow field, but where this pyramid that you just showed, maybe as long as the research is done well, is totally appropriate, but there's lots of fields where it's not. And I think that's really the point, sort of this matching a question to a method. And I think often people even struggle more with really specifying what the question is that they're asking and and sometimes there's sort of almost automatic response what method they should be using, usually the method that they're best trained in or have the most experience with. And that, I think, sometimes creates the bigger problem that you're using the one tool that you have to answer lots of questions, even if it's not appropriate. And I think, so I'm not against hierarchies in general. I think they have to be, you have to rank these different sources. And I think we had that very nicely in the first talk. You have to think about these different sources and whether or not, or what part of the question that you're asking they can reasonably illuminate, and where you have to look elsewhere. And in the life course of an intervention or whatever, you probably need different tools along the way. And that's, I think, is really a key problem. And the confusion starts when you are not clear about what stage you're in or what question you're using, because then you don't know what tool you should pick from your toolbox.
Yeah, this reminds me of a question I was asked quite a lot when I was an editor, which is that people would say, do you publish papers which use this method or that method or the other method? And I always thought that was a very strange question, because I like to keep things simple. My question was always, well, is it a good research question to ask that's going to have impact, and have you used an appropriate method? And if so, that to start with the method is really putting the cart before the horse. I quite agree with that. So I'd like to move on to a question which is from one of the audience. This was sent in before the symposium, and it's quite a specific point this person's making, but I'd like to broaden it out a bit. This person has asked, what is the current impact of evidence-based psychiatry/psychology on Freudian and Lacanian psychoanalysis? Now, you're all looking a bit alarmed. I'm pretty sure there are no Freudian or Lacanian psychoanalysts among you. But I'd like to draw the broader point from this question, which is that there are certain things in mental health, certain practices, certain outcomes, which seem to resist the approach of gathering evidence, where people will say, well, we're looking for something in the relationship between the therapist and the patient, or something in the effect of a particular substance, which is ineffable, which we cannot measure with the usual kinds of scales. And because we don't have those things, they're disregarded, they're thought of as ineffective and non-evidence-based. It's just they don't respond to the usual rules for collecting evidence. Now, to some extent, I've great sympathy with things that are very difficult to measure and difficult to capture. That's what a lot of mental health is about. But there's part of me as well which wonders if that's kind of special pleading a bit. And I wonder where you as a panel fall on this, whether when there are things which people say, well, we can collect, we can't quite measure it, where that falls in this whole net of evidence base that we're trying to cast. Yes, please go ahead. Gracelyn.
Thanks. Yeah, this is something I feel pretty strongly about, I'd say then too. And I think it really comes back to, again, what the idea of that, I think that's a very kind of potentially narrow view of evidence. And when you're thinking only about kind of the idea of like measurability, then again, you're leaving out these ideas of values and preferences and expertise, going to which Dr. Slider was saying then about lived experience. And more importantly, kind of, again, that training that I've had then in system science that I mentioned during my talk was this idea of that when we say that we can't measure something perfectly, and so we just don't measure it, we're saying that it doesn't exist, it's not true, it's not happening. We always, even in our quantitative, we pretend that, in quantitative modeling, I think in particular, whether it's even just an OLS, ordinary linear regression kind of thing, then we're saying, we always say ceteris paribus, holding all else to be constant, that nothing else is changing. We know that's not reality. That's the kind of a statement we need to make to be very clean about the way that we're drawing our causal inferences. But that's one of the reasons that I feel very compelled to kind of move towards other methods then, such as system dynamics or qualitative approaches then that really contextualize what we're observing in a quantitative space, because we know everything else is always changing. There's not a world then where, you're just changing the intervention and nothing else is happening in these people's lives or the settings in which we're doing it. And so again, I think it's where those complementary types of evidence are really important.
Thank you. Any other points on that, on the difficult or the impossible to measure, and where that fits into the web of evidence? Sinja.
Yes, I've sort of in between here, a bit torn as well, because I do think that we have a certain role to fill as researchers, and we represent a certain a type of knowledge. So I acknowledge that various types of knowledge that do not also come from the research community can help us understand a phenomenon. But I think we need, as researchers, to think about what our role is. Is that to generate systematic knowledge? I do think that that's the case, and I think also maybe we should be very keen to not resort to saying that there's stuff that can't be measured. Obviously there is, but we have to be very dedicated to figuring out whether stuff that's difficult to measure can actually be measured and analyzed. So I think that's sort of our role in this, and there could be other professionals that have other roles in contributing to our knowledge in specific areas, but we have a specific role as researchers to fill out, and I think that's generating systematic knowledge.
Thank you. Stefan.
I just want to make maybe a bit of a provocative point to that, because the example that you used was saying, well, some things get dismissed because they can't be measured, but there's obviously also a second side. Some things are being claimed as being true because they can't be measured, right? And I think that's both of them are dangerous in a certain way. And I think if we're, or I'm not sure about dangerous, but that makes it in a way unscientific. And I think Jasper had some really great examples. There are ways of measuring very personal experiences or very specific ways of perceiving things, and we don't have to get into a philosophical fight about what's reality and what not. And I think that there are ways of generating evidence, but if we move into an area where there's non-testable hypothesis, I personally would say it stops to be science, right? I mean, I'm not saying that, but if you claim that it can never be tested, that to me is not a scientific theory. So I think in a way, we have to use these different methods, and there's different tools, and there will always be areas that are hard to do, but it's a bit on the people who are proposing these models to come up with ways of measuring them, rather than saying it can't be measured, must be true, which I think is a bit of a cop-out.
Thank you. Gracelyn.
Sorry, just one additional comment on that then that Dr. Gold just made me think about then is this idea of like, even when we measure things quantitatively and we say it's the same construct across different measures, is it truly? So I am very influenced by one of the first projects I've ever worked on that was an individual level data meta-analysis. And we compared, it was for adolescent depression prevention and treatment interventions. And even amongst the prevention interventions, there were 10 different measures of depression. And we tried a lot of different really cool ways that I couldn't explain anymore now that people far smarter than me did, from different types of multiple imputation, data harmonization methods to really see, even across these trials, as something like depression that we think that we measure so precisely often in studies then quantitatively. Can we harmonize those measures to really compare, should we be comparing these trials head to head and, in a meta-analysis, things like that. And it was extremely challenging and we kept finding out that it wasn't. So I think I just wanted to put a pin in that of like really thinking about data harmonization, construct harmonization, just because we are measuring it and saying it's the same construct. Is it really?
Thank you. And Jessica.
I just wanted to note quickly, a lot of the time when folks say this is not possible to measure, what they mean is actually this is not possible to quantify. And that quantitative research and quantitative data are not the only kind of valid data. There are highly valid methods of rigorously, systematically evaluating qualitative data sets. And for some of these constructs that are more difficult to capture, I would say that this is going to just require sort of a cultural shift in psychology and psychiatry to accept systematically analyze qualitative data as a valid and rigorous form of research, rather than something that cannot inform future work. So I think that although there is some openness increasingly in the intervention science space, at least, to systematic qualitative methods, I think we have a long way to go, and they're still sort of deprioritized. In fact, when I was in graduate school for my dissertation, I was told that I couldn't include qualitative analyses because they wouldn't pass the sort of level of rigor that was expected of me for my dissertation. So there's a definite bias there that I think is holding us back.
Thank you. And Jasper.
Yeah, and I think to follow up on that, sometimes when people emphasize that something can be measured, just shows that not all that matters in a human life is about empirical science and empirical observations. And sometimes it's more, for example, in my field, psychosis research, sometimes people adduce a significance to these experiences that is more a question of existential value and existential meaning. And when they emphasize that this isn't part of empirical science, of course we can try to measure these existential attitudes and values, but the very fact that they have this meaning, that's something that seems to escape empirical science. So we should, I think, even as scientists, be open to that and respectful to that.
Thank you. Senior.
Yeah, just wanted to support Jessica's point. As I said at the beginning of my talk, I'm a sociologist by training, and in sociology and also other social science disciplines, there's strong qualifications in doing qualitative stuff and collecting and analyzing qualitative data in a systematic and transparent and rigorous way. So I also sort of call to people in the mental health studies to look at other disciplines and see how they are doing in integrating or at least defining other types of data and analysis than just the quantitative ones.
Thanks. And that raises another question, though, surely, which is that one of the risks of saying that they're there are all kinds of different types of evidence for all kinds of different research questions, don't we then risk really getting siloed as a field, that we're all pursuing our individual lines of question and evidence and never coming together and never synthesizing that into a whole? And then there's the risk, as you've pointed out, Jasper, in my own experience, which is that people misunderstanding not only the value of qualitative research, for example, but just how this stuff actually works, what the nuts and bolts of it are. So how is it that in this highly specialized area where we all have our own little thing, that we can actually come together, that we can understand the value of what each other are doing, the practical nuts and bolts of what each other are doing, and really synthesize that together to get a more holistic view of the questions that we need to answer? Or perhaps we can't. Ah, good, senior.
No, so I think it's a really tricky question. So as I said, I'm trained as a sociologist. I work in a research environment that's very quantitatively oriented, and it's quite clear that there are silos, and it's difficult to get each sort of perspective to acknowledge each other. And I think, especially, and also going back to the triangle you presented initially, that there is this idea that the quantitative stuff is better and more closer to the truth. And I think it goes down to the individual level of encouraging people to be curious about other methods, to be respectful of it. And I think it also comes from experience. So as I said, I've been working with econometric methods my whole research career. And I so many times face sort of challenges when I present my work, especially to practitioners, about the underlying stuff. So you get this causal effect, but what does it mean? So I think also that experience of continuously being presented with that sort of critique or question when you present your own work raises this awareness that this is not the only truth that's out there. But I think training students to be respectful and also training them in different methods already at university or college is, I think, key to this.
Thank you. Jessica.
I think there are a couple of possible strategies that could be taken or considered. One is starting with what are the questions that we want to answer rather than what are the methods we deem reliable or not reliable, and coming together regardless of the methodology of choice that we favor and agreeing these are the important bottom line things that we need to communicate through various research methods. Two is acknowledging that there is no one research method that's going to answer whatever questions we deem important, and that triangulation of research triangulation of results across multiple methods is going to be necessary. Just as one example, in intervention studies for depression treatments, the National Institute of Health in the US requires that we use a certain standard battery of measures as our primary outcomes, like the PHQ-9. There's really interesting and I think undervalued qualitative research with patients, where patients are asked, if you were designing a depression intervention trial, what would be your outcome of interest? What would be the most important thing to measure? And none of them say the PHQ-9. They say my own life problems, functioning. And the functional items of the PHQ-9 are often left out entirely of these clinical trials and not reported on at all. And so relying solely on one source of data, an RCT with the PHQ-9 as a primary outcome, is not going to actually get you closer to a treatment that addresses outcomes that the patients care about the most. So that's one example where triangulating across multiple data sources would be important for answering the question of what intervention produces the most life improvement, quality of life improvement for folks experiencing clinical levels of depression. So I think that it doesn't necessarily have to be the case that everybody understands the methods perfectly that everybody else is using. But if we're aligned on the questions that are important to answer and all agree that no one method is going to be sufficient to answer any given question, I think that's at least a starting point.
And so I'd like to follow up actually with a question from the chat, which Vijay has asked, which is directed towards you, but everyone else is welcome to answer this question as well. Is there a need for change in the dominant skeptical narrative regarding lived experience, verification and validation as a means of evidence generation? Can and should lived experience be used as at least one leg or arm of evidence triangulation?
Well, if that's directed towards me, then yes, is my answer. Some funding agencies do a really nice job of this. Welcome actually requires lived experience components to any research proposal, which I really appreciate. But typically, you know, what does that consist of is often relegated to like a one-time consultation with a lived experience expert or something sort of superficial, or feedback on outcome measures rather than identifying questions that are most important to answer in the first place, or identifying intervention methods that might be worth considering. So I do think the scope of folks or experts by experience and what they can contribute to research does need to be expanded, because right now it's sort of structured as they're presented ideas from the experts and tell the experts what's good and bad about it, not like they come up with ideas to test. And that's actually considered with equal weight of scientists' ideas to test.
Thanks. Does anyone else have any thoughts on this, on lived experience as evidence? I suppose it kind of touches on your work, Jasper, though I think it's probably relevant to all of the work that we've discussed here.
Yeah, shall I answer or? Yeah.
Yeah.
So yeah, I mean, yeah, obviously. So I think that lived experience is immensely important, not only as a sort of, as Jessica mentioned, as a sort of additional check, a nicety to include in the research design, just to ease our conscience. But no, from the very start, to generate the type of questions we deem relevant, the sort of concepts we use in our research, and across the board, actually. But on the other hand, I also think that more needs to be said and more research needs to be done about lived experience expertise itself. What does it actually involve and what does it actually consist? And I know that, well, in recent years, there has been a trend towards more acknowledgement of lived experience, but these type of questions really need to be developed further, I think, in future research and future studies.
Thank you. So we've got a little bit of time before we have to close this part of the discussion and bring on Matt and Beth. I'm going to choose another question from the chat. And this is an absolutely massive one, I realize now looking at it. It's a question from Arun, who is from Sri Lanka, and wonders, given the origins of mental health problems are multifactorial, what is the role of research in phenomenology to diagnose diseases? Is it useful to look at individual cases again and re-establish the diagnosis in a specific culture rather than labeling things according to ICD and DSM? Is there a reason why we don't seem to get a lot of new knowledge from studies, because we are stuck in 20th century psychological and psychiatric models? So that's an interesting question, which is the other factor, of course, in mental health, is the cultural, and how different cultures and different cultural conceptions of mental health problems might affect our thinking about evidence, about the experiences we gather, and how we apply the evidence. I wonder if anyone has some initial thoughts on that rather huge topic. This, I think, I'm afraid I'm going to turn to you, Jessica, because one of the things about digital interventions is that, of course, the scale which they can operate is fantastic, but this also means that you often have to think about how interventions work across cultures. And it struck me that some of the examples which you use seem to be very specific to a sort of US culture. So I wonder about the cultural adaptation of thinking really in terms of those sort of huge scalable digital interventions, and how you'd look at the evidence in that context.
Sure, great question. Phenomenology confuses me, so I'll do my best.
Well, I took several years learning how to pronounce it, so yeah.
Well, good. I'm off to a good start then. Excellent. So I really appreciate this question, because I don't think that labels stemming from the DSM and ICD are all that helpful if you think about efforts to take a population health approach to addressing mental health challenges, because most people will never get a diagnosis. Most people won't even get their foot in the door. They'll just know that they're struggling with something. So figuring out how we can create interventions that target universally relevant underlying factors like a sense of hope or a sense of personal agency, or a sense of belonging. I think these are the things that will allow the interventions that are highly scalable to have at least a fighting chance at more universal cross-cultural impact. It's true that the interventions being tested in the mega study I presented today, we're testing them in the context of the United States. So that study, we're not saying is automatically going to generalize across cultures. At the same time, in our research lab, we have a publicly available website called Project Yes with a host of different single session digital interventions that have been co-designed by youth, designed to target depression and anxiety. But really they, target these underlying factors like hopelessness, self-hate, and belonging and self-efficacy. And we have translated them into 9 different languages, done co-design work internationally, and the results of the interventions on things like depression, anxiety seem to be pretty consistent across cultures. And the adaptations are often quite surface level, like examples or the stories from peers that we include, rather than the core psychological targets that we're identifying and seeing movement in. So I do think, we need to be vigilant about involving folks that we're creating these things for in the adaptations. But I think assuming that cultural adaptation is going to require total overhaul of interventions for every individual community would also be a limiting assumption. So I think relying on those core mechanisms to guide what interventions can be universally deployed or safely deployed to a large portion of the population, and involving end users at some level early in the process to ensure acceptability, I think can circumvent some of those problems and gets around the issue of requiring a diagnosis entirely.
Thank you. So we have unfortunately run out of time for this panel discussion. So I'm going to put my final question to everyone. This is really, I guess, an elevator pitch, with the elevator being in a particularly short building. I'd like concise answers to this. And the question is, what's the single major change that you think needs to happen in the way the mental health field generates and evaluates evidence? And I'm going to start with Stefan.
Just one thing, I think we have to overhaul the system, how we give credit to evidence generators, and that includes everybody who could possibly generate evidence, because it's very academic, and that might be one of the reasons of the problems.
Thank you. Sinja.
Yes, so I think the important message would be to start focusing on the problem that needs to be answered, and to, after that, find the appropriate method, type of data that can be used to answer this problem or this question.
Thank you. Jesper.
Yeah, unsurprisingly, I think that mental health research, more than it does today, should ensure that the evidence it generates is effectively grounded and adequately grounded in subjective experience of patients.
Thank you. Jessica.
So in addition to agreeing with everything everyone's saying, I'm taking a more pragmatic approach to answering this question, because none of this research happens without funding. So requirements by funders, I think, need to change to systematically require different sources of evidence, and to start to dismantle this assumption that there's one method or one approach that is, automatically superior to others. So that would be my answer.
Thank you. And finally, Gracelyn.
I also agree with what the other presenters have said, but I'll add, kind of taking a different direction, that I wish that mental health evidence generation included more investigation into social and structural determinants of health instead of more clinical outcomes. And I think that would really help support the evidence base and improve lives.
Thank you very much. And thank you to all our panelists, and thank you to our online audience for such fantastic questions. I'm now going to turn to Matt and Beth, if you could switch your cameras and your microphones on. For those of you in the audience who weren't with us right at the beginning of this session, Matt and Beth are the people who are behind, or two of the people who are behind the Lancet Commission, which really prompted this discussion today. So Matthew Eisenberg is a health economist and associate professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. Beth McGinty is the Livingston Farrell Professor of Public Health and Chief of the Division of Health Policy and Economics at Weill Cornell Medical College. So, Beth, if you could turn your camera on, that would be fantastic. I'm afraid I can't see you right now.
I have it turned on and can see it
Great,
on my side.
I can see you now. That's fantastic, and hearing you loud and clear. So I wonder if you have any initial reflections on the discussion which you've heard today and how this links with your work on the Lancet Psychiatry Commission.
Yeah, absolutely. I want to start out by thanking our fantastic group of panelists. This was a wonderful way to spend my Thursday morning. It's morning here in New York where I'm sitting. So thank you to all of you. I think what really struck me about this panel was the excellent exemplification of the different kinds of evidence that we need to inform rigorous mental health implementation research. One of the core recommendations in our Lancet Commission report was to expand the use of non-experimental approaches to establish causality. And we saw here just an array of those types of approaches ranging from, econometrics to system science to qualitative research. I think reflecting on this panel, I think perhaps if I could go back and rewrite this recommendation in the Lancet Commission, I might broaden it a bit to rather than simply expand the use of non-experimental approaches to establish causality, which I certainly still agree with, but to move beyond the laser focus on the traditional randomized controlled trial, I think might be how I would think about this. And this panel, I think, did such a nice job depicting the ways that we can and already are in the work that we heard about today, sort of moving beyond that traditional paradigm. RCTs are an amazing tool, but they are not enough. They are one narrow type of evidence. And, I loved in particular the point about often what we might want to do is to augment RCTs with additional kinds of data. It's not throw the RCT out the window, it's sort of broaden our toolkit. So that plugs in really nicely to our commission report, and maybe in commission report 2.0 has sort of informed my thinking about how we might broaden that recommendation.
Yeah, I want to echo Beth and first just thanking everyone for participating in this great discussion. It's been such a fun morning on a topic that's very, very near to us. I think that, like Beth said, this really plugs directly into the commission report and one of the core recommendations. I think one thing that the commission was particularly focused on is scale up and implementation, right? It was the Commission on Implementation Research. And I think even this broader view of what constitutes evidence is applicable in all types of research, but I think it's especially relevant in implementation research because you don't get as many opportunities sometimes in implementation research to do the classic RCT. So you have to be a little bit more creative, a little bit more adjustable and willing to engage in a variety of different methods when trying to do that. The other thing that came up on my mind listening to this is that one difficulty in communicating our results to the public and communicating results to policymakers is we as scientists want to fully explain all of the benefits associated with the research design, as well as all of the long, long list of limitations and caveats, right? And unfortunately, or fortunately maybe, our partners in policymaking don't have the time often to engage in the nitty-gritty of what assumptions need to be met in for what different research design. So I think as we bring different researchers together to try to look at different types of methods for evidence generation, I think we also want to think about the end user in mind and carefully balance our ability to draw clean, easy to digest conclusions while still conveying the nuance associated with our results. But yeah, those are some initial thoughts. I think this was great.
So that is a big question, which is how we get the evidence out of the academic circles, how we stop evidence sort of ratcheting between conferences, journals, and funders, and get it actually out there and to policymakers. And that's one thing which you've said, which is that it's simply a matter of communication. But I wonder if are there any other things that either of you could think of in terms of moving evidence to implementation? Do, for instance, researchers need to think perhaps more entrepreneurially about how they promote their work and disseminate it?
Yeah, and I think the one thing that I found with communicating results for policymakers and talking to researchers who research the science of research to policy is the importance of not thinking about it as translation, but thinking about it as a partnership, right? So this means communicating with the end users kind of throughout the process. And this was another piece of the Lancet report, one of our recommendations was trying to get away a little bit from the more traditional research to translation pipeline and try to take a more integrated approach. I think that's specifically relevant when communicating results to policymakers, because the relationships matter, building the relationships matter, and they take a lot of time to do that. So I think back to the funding area, I think that funders need to recognize and fund the important translation piece of this and the relationship building between the end users and the researchers in order to make that type of repeated connection feasible.
I agree with everything Matt shared. I think that this ties very directly to one of the commission recommendations, at which sort of overarched many of the points made today around replacing the linear research to implementation pipeline with an integrated approach. And in an integrated approach, we are engaging with people who will use the evidence across the research production process, including pre-research production and the research planning process. In my own work, I'm a policy researcher who focuses a lot on policy implementation, and it's critical for our team to be in, fairly constant dialogue with policymakers to understand what kind of evidence they need to inform decisions. And in some cases, we co-create research with policymakers. Jessica was making really great points about this sort of co-creation idea in the context of people with expertise drawn from their lived experience of mental illness. But I think we need to think about co-creation in terms of the people who will ultimately use the evidence, writ large, which can include policymakers and health system leaders and community leaders, a whole range of what we've traditionally called audiences, but who should be co-creators rather than passive audiences.
Yeah.
So there's something here I'd like to pick up on. We discussed it a bit earlier, but I'd really like to hear your take on, which is that we've talked about lots of different types of evidence. We've talked about how the evidence is really gathered ideally to answer an appropriate question on an appropriate part of a question. And we end up potentially with, say, the subject of psychosis, and what we could have as phenomenological evidence there. We could have trial evidence there. We could have epidemiological evidence. There might be some evidence coming in now from digital interventions. How do you synthesize all these different angles on the same issues into a coherent message for implementation?
I went first last time, Beth, so I'll leave it to you to go first on this one.
I'll take a stab. So this is an inherent challenge in science, right? All of those different perspectives that you just alluded to Niall speak different languages. They're using different terminology. They are approaching issues from different perspectives, right? And so bringing that all together, never mind figuring out how to sort of make it cohesive for somebody who's going to consume it and wasn't involved, but even bringing it together for the people who are involved in producing the evidence is a challenge. So, I think that for me, this really links to, again, a core idea in our commission, which is the need to build transdisciplinary research approaches. And this is easier said than done, right? Easy for me to wave my hands and say, let's do transdisciplinary research. Doing it in practice is really challenging. And the systems in which we produce evidence, don't support it. We have academic departments that are segmented by discipline. One gets promoted within disciplinary bounds. Even outside of academia, we have evidence production infrastructure sort of in very narrow bands, like the pharmaceutical industry understands one little tiny piece of science, for example. So we talk about some ways to think about this in the commission report. And I think to do it well, it really does require a bit of a transformation of the research enterprise writ large. I think Stefan made the point that we need to sort of overhaul the system of giving credit to evidence generators, including who evidence generators are. And this is very much in line with that. But some tangible things here that I think can support this are, starting early with transdisciplinary training experiences, even if someone is not doing a transdisciplinary training, transdisciplinary PhD per se, there are not that many of them. Making sure that we have sort of research training pipeline experiences where people can interact with other disciplines regularly, and that we carve out space and sort of very intentional opportunities for us to learn each other's terminology and perspectives. I think funders are increasingly moving in a direction that supports this kind of work, honestly, as we move towards, really a team science environment where I don't have any funded grants that don't have people from multiple disciplines on them. And so I think in some ways, the research enterprises is moving in this direction, at least in terms of funding for large applied mental health implementation research projects. There's recognition of this. Academia is lagging behind here in terms of, keeping people constrained within narrow disciplinary boundaries. I'm criticizing academia. It sounds like I will say there's real tension here in terms of, sort of developing very strong expertise in a discipline, and sort of how do you think about transdisciplinary training where the concern might be like, okay, you know a little bit about everything, but you have deep knowledge about nothing. So easier said than done.
Yeah, I agree with everything Beth said. The one thing I'd add is that I imagine in this audience, we have a lot of true believers in this and might be wondering, like, how do I get started doing this type of work? And I'd say that the first step in building transdisciplinary research and transdisciplinary teams is trust, and building trust across people. So if you're looking for somewhere to start, be the change. Start a transdisciplinary work group in your environment. Start talking to each other about each other's research. Be genuinely interested about learning the methods that are not methods that you are familiar with. For my personal background, right, is that I'm a classically trained economist. And now I do mixed methods projects that have qualitative pieces, which if you told me 15 years ago in graduate school, I would have said qualitative. I don't know how to do that. But now with years and years of trust building and interaction, we can actually get there. So it takes time. It's slow, but don't wait for someone else to create that space for you. Create it yourself and get out there.
Thank you. So that's an optimistic note to end our discussion on, but I just have one more question. It's the question which I asked the panel just now, and that is, what is the single major change that needs to happen in the way the mental health field generates and evaluates evidence? And I'd like to start with Beth.
I think we need much greater emphasis on mixed methods research. I think I really appreciated the conversation about the tensions between qualitative and quantitative, and quantitative also often being perhaps overvalued. And I think mixed methods can really bring together the unique strengths of these two approaches.
So my answer was also going to be mixed methods work, which is not surprising because Beth and I work together on some mixed methods projects. But so thinking on the fly right now, I'll say that I think the one change would be broadening the understanding of these different types of methods. So even if you're not going to employ them, be willing to engage with them, be willing to critique them, be willing to listen and be a part of it, even if you're not going to generate it yourself.
Thank you very much, Matt and Beth, and thanks again to all our panelists, and thanks to you in the audience. I really hope you've enjoyed this discussion as much as I have. And if you'd like to complete our evaluation form, I'd encourage you to do so. So Anna has just popped the link in the chat, so you can click on that and tell us what you liked, and indeed what you didn't like about the session. There are more symposia on the way from IMHRF, so please do stay tuned for those. But for now, I'd like to thank you again. This was a great discussion. I think we have many, many points that as a community convened by IMHRF and Lancet Psychiatry, and indeed by Wellcome, we can move forward with to improve mental health research for the people who really need things to change. So thanks again to everyone, and I hope to see you at a future event. Goodbye for now.
Thank you.